afraid I'm substituting the expert, so I'm not really an expert in this particular field, but I know a little bit. And what I will try to do, I will try to address in a more general terms whether or not we should use the ejection fraction to decide when we should prophylactically insert an ICD in our patients. And first of all, I want to share with you the dimension of the problem, because sudden cardiac death is really affecting just a little bit less than 500,000 of Americans who are dying for sudden cardiac death every year. In Europe, the data are more scarce, and you have to consider that Europe is a federation of many different healthcare systems, and so it is more difficult to collect all this data, but they are similar. And when we are looking at the epidemiology of sudden cardiac death or sudden cardiac arrhythmias, you can see that the amount of death is really more than the amount of death for stroke, lung cancer, breast cancer, and ADS, putting all together. So we are really talking about a very serious problem. And all these sudden cardiac death, 88% of them are due to arrhythmias. And therefore, if we are able to detect them, we could avoid this unnecessary death. And it follows that the prevention of sudden cardiac death is of paramount importance. We went a long way from the 1970s when Mirowski generated the first ICD, which was put into a dog, to the situation of today. And there is a long history starting from 1947 with the first internal defibrillator inserted in men, then the external one almost 10 years after. Then in 1970, the first ICD in dogs, and look, it was weighing almost 1 kilo. And now we are inserting ICD of 60 grams. And also the first one in men was implanted in Baltimore in the US. And if we take a closer look to the sudden cardiac death at 1 year, you can see that the incidence in the general population is very low, but the absolute number of events is very high. The same if you are selecting high-risk subgroups or also before any prior coronary events. Very low incidence, but rather high absolute number. And if we are taking the ejection fraction below 30% as a cutoff, which is what we are doing now, and we are doing that because these are the patients which has been enrolled in most of the clinical trial, and as you know, the guidelines are made out of the clinical trials, you will see that you have a rather high incidence, but the absolute numbers that you are preventing are very small. So the meaning of this is that we do have low incidence in the population, but high numbers of absolute events, and these are the patients that we need to be identified. But these are the patients in which we are not able to identify. And the data from the randomized clinical trials relate to a minority of patients with an ejection fraction less than 30 or 35%. And this is minority in the absolute number. So really we are lacking of a good identification system. The guidelines are telling us that the guidelines are really driven by two major clinical trials, which I'm sure you are very well aware of. The SCD-F mortality rate was quite significantly and importantly reduced by the insertion of the ICD when compared to placebo or to antiarrhythmic therapy. So very good results in this sense. Even when we are looking at the mortality rate in non-ischemic patients, there was an advantage to have an ICD implanted, and again, very good results. These good results were obtained mainly in patients in the New York Heart Association Class 2. You can see a very clear advantage to have an ICD. The situation, however, is different if we are talking about patients with more severe heart failure. You can see that the mortality rate in this case is no longer reduced by the implantation with the ICD, and it is very, very similar to the one of placebo. The other trial was the MADI-2 post-acute myocardial infarction, again showing a better survival if in the defibrillator group when compared with the conventional group. Also, please notice that the advantage is obtained after 1 year after the implantation of the ICD, and this long term before to have or to enjoy a difference was also present in the previous trial, actually after 18 months. And also it is quite relevant to say that in elderly patients, and for elderly it means above 75 years, there was no benefit from ICD implantation. So although I'm not an expert in the electrophysiology, what I'm making about all this data, and these are just considerations, is that perhaps the ejection fraction is a good index, is a good cutoff, but we need to consider other things. We need to consider how old is our patient, because perhaps after 75 years is not a good idea to insert an ICD. And this is particularly striking in my country when we have a limited amount of money to treat our patients, and we should select the patients who will benefit more. Then we need to ask ourselves, does the patient has major comorbidities? For instance, kidney disease or severe kidney disease may be something that will allow us to consider the ICD implantation and also the state of heart failure. What is his life expectancy? This is another important point. Is the reduction of ejection fraction due to ischemic or to cardiomyopathy? And that is also another important point, because the response is more clear in the ischemic cardiomyopathy. Of course, I'm not talking about the hypertrophic cardiomyopathy, which could be prone to ventricular fibrillation. And what is the functional class of our patients? So you see, there are a lot of questions behind the ejection fraction that one should ask. But why we are therefore using the ejection fraction? Well, first of all, because this is what the clinical trials are telling us, and also because ejection fraction has several advantages. It is rapidly and widely available. It is used in the trial, does not expose to any radiation. But we have to consider that has also some disadvantages. It has a limited sensitivity and limited positive predictive value. It does not provide any information on the anatomic substrate and on the triggering factor. And it does not really provide several information of the patient status that I referred to before. But perhaps this lack of information of the anatomic substrate and triggering factors is quite important, particularly in ischemic cardiomyopathy, because the substrate is represented by the area which is around the SHA, and the ejection fraction does not really tell us very well about this area, which could be still viable, but could be very prone to be a trigger for ventricular fibrillation. And so here is where the multimodality imaging could help us a little bit more and on top of the measure of ejection fraction. And the principle is based on the evaluation of that the more scar you have, more Borden zone you should have, and more risk of arrhythmia. So in this sense, the ejection fraction has a sense, because if there is a lot of scar, you would imagine that the ejection fraction will be low. But really, you have no idea about the Borden zone. And that is where the magnetic resonance, the speckle tracking echo, and also some particular nuclear imaging could be important. Just a few examples, you can say with the magnetic resonance very well the area of scar, and you can define the amount of the peri-infarct zone, which is the anatomic substrate for the arrhythmias. Speckle tracking can be important, both the radial and the longitudinal one, because it can identify again this area of necrosis and of the area around the necrosis, and also the nuclear imaging. And the nuclear imaging is done with the technetium in order to detect the viable myocardium, and also with this substance here, which is called the methyl-iodine benzyl guanidine, which is a technique, which is a tracer able to detect the adrenergic cholinergic receptor, or if you prefer, the autonomic not intervention, but innervation. And when both the viability and the autonomic innervation are present, and they are comparable in terms of size, you have a very low probability of arrhythmias. But when there is a discrepancies, there is a higher probability of arrhythmias. You can see here a very good balance ratio and a completely disratio in this imaging. So I like to put down to you that the majority of the patients with sudden cardiac death, unfortunately, continue not to be identified, and that will be a problem. The percentage of ejection fraction is the most available cutoff to identify patients at high risk, which are worth to have an ICD implanted. However, the percentage of ejection fraction is not sufficient, and the patient's characteristic has to be considered. Always, we need not to practice medicine according to a number, 30%, but according to the patient who is in front of us. And of course, you need to do an echocardiogram to see whether there is an hypertrophic cardiomyopathy, as it was done in the patients before. The multimodality approach seems to be promising, but for the present time, it needs to be more carefully evaluated. It's just a promising opportunity, which I'm sure will be evaluated in the future. Thank you very much for your attention.